the data, so the Southeast COVID-19 kind of recovery story, which Steve and team will be able to share in more detail. But looking at the data from April to June 2021, and also sharing the COVID-19 modelling tool, which Steve and colleagues you've developed. So it's going to be a good session. And then we're going to have a break, and we're going to be having a focus session on community mental health and really looking in depth at what the data is. So the presentation, I think, Steve and colleagues for community will be in the second part, so that won't be covered in the first part of the session. But having said that, we are recording. So for anybody that does need to go, we'll make sure we record the second session as well as the first. And we'll be able to have some discussion in relation to what that data is telling us, and I think sharing some insights and thoughts from colleagues in the meeting in relation to that. But it would be good, just before we hand over to you, Steve, and NHS benchmarking colleagues, is just to do some introductions. So I'm just going to go to you, Michelle.
Yep, so I'm Michelle Vassallo. I'm the Senior Quality Improvement Manager in the South East Mental Health team. I've pressed the record button, so if you don't want to be on camera, I would switch your camera off, but otherwise make sure you've got some water, because I don't know where you are, but it's very hot where I am.
Brilliant. Thank you, Michelle. Sam, it would be great if you could introduce yourself as well in relation to particularly the community session later.
So hi everyone, I'm Sam Angelo, working on community mental health transformation for the South East region team. Really great to see some of my community for transformation colleagues on the line. It's shaping up to be a really good session later. I feel a little bit odd saying community for transformation colleagues because it does involve everyone, but really great to see you, and thank you for coming.
Brilliant, thank you, Sam. And Steve, I was just thinking over to you, but also if you wanted to introduce your NHS benchmarking colleagues as well, that would be great.
Fabulous. Thanks, Katrina, and thanks Michelle and Sam as well. Yeah, believe it or not, we're all sat up, well, mostly in Manchester, and it's incredibly hot. I've just had to evacuate my room because it was 35 degrees, but that's because the air conditioning in the building is broken and it's a big glass box. So I've not quite got my usual composure, but I hope you'll bear with me, and I'm sure I'll find my feet. But I do have the full team with me today, so I'm delighted to let you know that the people on the call, as well as myself, so I'm the director with NHS Benchmarking. We also have Ellie, and Ellie has helped to mobilise most of the Trust COVID data over the last 16 months or so. Also have Janet, Stephen, Mike, Alison, Alex, Jack, Aidan, who's actually built the modelling tool, which we'll be giving a quick run out later. And also one of our other directors, Sarah Atkinson, has joined us for the first time today. So we've come mob-handed, and that's really because we're interested and we care about this work. And in many ways, it's a synopsis of everything that's happening in UK mental health services at the moment. And the great thing, of course, is that we've got that data from the rest of the UK's mental health services to share with you today. So we can put that Southeast story in context. Every trust has its own story, the region has a story, but in many ways, I think that overall direction for what's happening of the UK, across the UK, can be a bit of a guide to us as well. So we're going to run till 3, just that usual discipline around getting the call optimised. If everyone could go on silent. The team are there in the chat though, and would really welcome your comments as you go. And Ellie's got firm instructions that she can stop me at any point. There's that classic Teams presenter fix where I'm the last person to know if anyone wants to ask a question, but Ellie will stop me, and we can pause at any point actually. So we have quite a lot of content for the first session, which, as Katrina said, is that sort of UK and regional highlight story for where we are at the moment, at the end of sort of June, July. We'll then take that 10-minute break. We'll try to squeeze in the modelling, very brief demo this side of the break, and also just a reflection on the literature review, which you can all source via the modelling. And then we're going to come back together at about 3:10 to talk about issues pertinent to community mental health referrals. Most people get their care in the community, of course, and there's a huge national strategy underway at the moment to optimise that community delivery and enhance that community delivery. So I'm going to share my slides, and hopefully this means that we can get into the presentation. So I hope that's there with everyone. I'm just going to kick off on the general assumption that that's there with everyone now. Okay, so in terms of what we are planning to cover today, we'll reflect on that UK position, also the South East regional story. We'll maybe pick out one or two trust stories within that, and of course we would very much welcome your observations from systems about what's happening for you locally. As Michelle said, call's being recorded, and our team will take a keen interest in the chat and try and give you answers to any questions you have in the chat as well. We'll pick up all three main dimensions of mental health services at the moment. So we'll look at inpatient care. We'll take a brief look at IAPS, and we'll squeeze CAMS in as well. CYPMH on this side of the break. Quick catch up on the literature review in terms of recently published papers. That modelling tool demo with any questions people might have, and then we'll go to the in-depth discussion around community mental health after we've come back from the break, around about 3:10 or so. This always fills me with joy, actually, that the fact that we wouldn't have these products, we wouldn't have this event really without the active involvement of providers across the region. And ever since we started this work, back at the end of last year, we've managed to secure that 100% engagement from providers, and also really importantly, the consent of providers. So we've got this massive commitment to transparency, which is evident across the region, which helps us to understand the COVID disruption, recovery and transformation story. So thank you to everyone that's been involved in this process of making their data available and working with us to help understand the data as well. So that's the baseline position that we're going to work with. And I apologise for this. We are going to start with the bed story, and we could start with the story anywhere, but in many ways, if we start with beds, it starts to introduce the concepts about the history of the South East model, which, remember, is very different from many other parts of the UK. So we'll start by looking at acute beds. Remember, in the modelling tool, you can look at any individual bed type within both adult care and also within CAMS. But of course, adult acute beds, they're typically just under 40% of all the bed capacity that's available delivered by the NHS. And if people are going to be admitted to mental health services, more often than not, it would be to an adult acute bed. Just for information, there are about 100,000 mental health admissions taking place across England each year, and about 70,000 of those would be into adult acute beds. So we get more throughput through these beds because generally they're short stay beds, unlike, say, long-term rehab or forensic beds, where the average length of stay could be 2 years and upwards. So the way these charts work, of course, is that we've got the whole of the UK's data with individual providers shown in blue. Remember, for these sort of blue and colour-coded charts, we're not just looking at England, but we're looking at a wider UK story, which includes Scotland, Wales and Northern Ireland as well. And what we've done is we've picked out the region's providers, the statutory providers, in certain colour-coded bars. The national mean average there, which is that horizontal line across the middle of the distribution, is that there are about 20 beds per 100,000 working age adults. So that's the national benchmark, and you can instantly visualise the South East data story from that, with all providers below that national average. The region's overall mean average position is 14 beds per 100,000 population. So that's about 30% below that UK national average. So we have a very different service model being delivered across the South East. It's one that places relatively low reliance on beds, and we will check this one out later in terms of the community infrastructure and the IAP services that are helping this service model to function. And one of the sort of cross-check measures we'll be looking to test is really, what's the level of community provision in the South East? Is it as low as the bed provision, or is it higher? And one of the big enablers, of course, behind this is the level of CRHT provision in terms of helping manage that front door and also helping signpost people into other aspects of the mental health system. So we're 30% below average in terms of the bed base for the South East, and you can look at the individual providers. There's only one provider actually which is relatively close to average, which is the Isle of Wight there shown in orange. And we know why that is. The Isle of Wight, as a relatively small system, respectfully, will suffer from elements of diseconomies of scale. But it's really pleasing actually that even with those diseconomies of scale, remembering the average mental health trust serves a population of 1 million people, that even on the Isle of Wight, you know, we're only looking at an NHS average position in terms of beds. The purple bar is Sussex Partnership, and if we look at the overall mental health needs index for England, the index is about 1.0. That's the national average. Sussex Partnership have an index of about 0.99, so very close to the national average. But when you look at the acute bed position there for Sussex, you'll notice it is maybe about 10% below the NHS average. So within Sussex, we've got that surviving on a relatively low bed base compared to local needs. All of the statutory providers, the other 6 providers, are positioned very tightly within that bottom quartile, which you can see there. And if I just read them from the bottom, so the pink bar there is Surrey and Borders, the green, they're the second lowest nationally in terms of their acute bed base per capita. The green bar is Southern Health, they're 5th lowest. The light grey bar is Solent, they're 7th lowest. The yellow bar is Kent and Medway, they're 10th lowest in the UK in terms of bed base. Then we have Berkshire and Red, 11th lowest. Then we have Oxford Health in blue, 12th lowest. So this is the pre-COVID position, and we're going to test this position now in terms of the disruption of COVID and indeed where we are now with the latest data. So the next chart is just really to conceptualise the South East against the rest of the UK. And you'll notice there that, remember we mentioned the Isle of Wight and Sussex Partnership as having, you know, almost close to average levels of beds. You can see that here from the map where they're coded slightly darker blue, but really consistently across the rest of the region. Remember, this is the pre-COVID position. You see that the providers have some of the lightest shades of blue compared to the rest of the UK. And where do we find those additional beds? We find them in London. We find them in the large metropolitan areas, Birmingham, for example, certainly in the northwest of England, Northern Ireland and Scotland, really quite evident high bed numbers. So let's look at what happened under COVID. So the top colour-coded bar here is shown in blue. That shows you the monthly position across the UK. That's 16 months of data there. And if you look at the first bar there, April 2020, you'll notice that there was a dip in the national UK-wide bed availability. That was really because we were protecting patients, we were protecting that bed capacity, we were creating contagion space effectively. And so the national bed base did fall by about 5% during April. And that's the story we'll look at for the South East in a moment. And since April, you'll notice there has been that gradual recovery up to a position which we reached in probably September of 2020, and then also in April and May, and pretty much now actually where we're very, very close to that historic bed base. So we've got a recovery nationally in terms of the beds that are available. When we look though at the South East position below, and this is the latest data actually for July now, we've got a good news story in actually that the region's bed base is now back to where it was pre-COVID, 14 beds per 100,000. You can see that the lineup of individual trusts is pretty much where they were pre-COVID. You'll notice though that Sussex Partnership, if anything, have shifted slightly to the right, but the rest of the region are very, very much within that lower quartile position. So we've now got a sort of new style of chart for you, and these sort of green longitudinal bar charts. This is actually the regional position, so the collective position for each of the 8 providers over the course of the pandemic. So you'll see there that where we started out with a bed position around about 14 beds per 100,000 as the pandemic broke at the start of April. And you can see that we did lose beds gradually. They came back though during September. As that third national lockdown played out over the winter, again, we were protecting some bed capacity there. There was maybe some more contagion space as the infection numbers rose. But the really good news again is that we're back to the steady state position now at the end of July 2021 in terms of having 14 beds per 100,000 population. That's the bed base, and we can look at what happened with length of stay. So the blue bars here, this is actually 9 years worth of time series data. This is UK-wide data now, which shows how we've had gradually increasing, marginally increasing pressure on average length of stay over the years. And this is really tied in with availability of beds, it's tied in with the acuity of patients, and also maybe with use of the Mental Health Act. And all of those things have been increasing in recent years. So final blue bar shows us at the end of March 2020, as the pandemic broke, we had an average length of stay of about 34 or so days. And then we pick up with monthly data on the red bars beyond that. So we started monitoring this metric actually in July, and you can see that by July we had a much shorter length of stay being reported, and that's really tied up with that discharge programme which was playing out across the UK through the spring and through that early summer period. However, as patients started being admitted, and one of the factors you'll probably all be aware of is that more patients were being detained under the Mental Health Act as we experienced that COVID recovery. So query whether that was about increased acuity or even just the process of being admitted to bed. But length of stay did start to increase, and you'll see that playing out in some of that monthly data there as we go through the rest of the year. So where are we now UK-wide? Well, we're at a position of 35 days average length of stay. So it's not too far off where we entered the pandemic, but we are quite different from where we were several years ago, where we had an average length of stay of maybe 31 or 32 days across the UK. We'll look at the regional position on this one in a second, because there's a very positive news story for the region here, actually, about how length of stay has been managed during the pandemic. That's length of stay. The top bar here is average length of stay in the pre-COVID position for each of the providers. You can see we have such a wide range there across the region. So we have Oxford Health on the left-hand side there having the highest length of stay actually pre-pandemic, and they were probably about 5th or 6th nationally in terms of long stays. And then we have Berkshire, Surrey and Borders also quite close to that national average with the Isle of Wight. And then we have Sussex, Southern, but low length of stay being reported by Kent and also by Solent. The bottom chart though is really just flipping that to where we got to by the end of July. So remember the regional story actually in the pre-COVID position was 33.5 days in terms of the average length of stay in that year before COVID for acute admissions. The really good news story though is we got down to 31 days by the end of July. So the region's providers have successfully managed demand and also managed to successfully manage length of stay by reducing it over the course of the pandemic. You'll see that the providers have pretty much kept their positions in the national ranking. Oxford have moved slightly to the right, which is good news. Berkshire, I think it's fair to say, have experienced some ongoing pressure and they've moved slightly to the left. You see Surrey have moved to the right. Sussex probably keeping their position, but also Southern moving to the right, as have Solent and Isle of Wight. Really some quite substantial shifts observed within the Isle of Wight actually, and Kent largely keeping their position. So a good news story in terms of average length of stay, in terms of where we are, in terms of the data at the end of July. Bed occupancy has been vexing people throughout mental health systems across the UK through COVID. And I think you're probably all familiar with how we've presented these charts. So what we've done is we looked at the 10 main specialties around mental health and learning disability services. So CAMHS is included within that as well. And each of those colour-coded pastel bars within each of those sub-areas of the chart represents a month during COVID through to the end of July. The end of July is shown in that light grey position. And each of the red dots on those charts shows the pre-COVID bed occupancy. So if you eyeball that chart, you'll see the adult acute emptying of beds almost at the start of the pandemic, the recovery, second and third national lockdowns creating pressure, and actually some of that occupancy easing, and then that recovery through the summer period. And I think it's probably fair to say that for nearly all bed types, we're now at a position where we're probably about 2 or 3% below historic pre-pandemic bed occupancy for each specialty. There are 1 or 2 exceptions to that. So if you look along that top line of specialties there, you'll notice that within eating disorder services, there is some increased pressure, which I think supports the anecdotes that we've all been hearing. Although remember the UK-wide data, we're still circa 80%, and it's not that 90-95% bed occupancy that we've become accustomed to within acute care in particular. Perinatal occupancy there next to eating disorders has also experienced some pressure, and occupancy now is much higher, maybe 10 or 15% higher than we used to in systems pre-COVID. But the bottom charts there, secure care, generally slightly lower occupancy. Rehab has come back pretty strongly. CAMS is a single specialty though, where we are increasing really quite striking increases in occupancy. I think the only comfort we can take on tier 4 CAMS at the moment is that even with all the pressure, remember this is UK wide, we're at a sort of sub 80% position across the UK. That isn't the position across the southeast, I know, where that story's really been quite acute with lots of young people waiting to access beds. And then some good news on learning disability on the right hand side, where bed pressures have eased slightly over the lifetime of the pandemic. So that's the national story on occupancy. We'll now look at the regional story. So we'll start with acute care. Remember that the way these charts are presented, the top chart there is the pre-pandemic position. So the region as a whole, pre-pandemic, had 94% bed occupancy for acute care. That's very, very close to the national average of 95%. And if you look at the chart, you'll see that Isle of Wight and Sussex, again, the two providers that have the closest bed stock to the national average capita were pretty much full all the time. Berkshire, Surrey, also very, very full most of the time. And then slightly below average, we had all of the other providers, Oxford, Southern, Kent and Solent. But look what happened during COVID, and we've got the July position there at the bottom of the chart. So the UK median average now for acute beds is 94%. Remember, very close to where we were pre-pandemic. Credit to Southeast providers, it's slightly lower in the Southeast now at 89%. So again, what have the Southeast providers done in inpatient care during the pandemic? Well, bed occupancy has a little bit more headroom now, and also average length of stay has reduced to about 31.5 days. So a couple of good news stories there. And you can see that nearly all providers have moved to the right-hand side on the bottom chart there. So certainly Isle of Wight and Sussex have achieved slightly more headroom. Providers that have moved to the right would be Kent and Berkshire. Pretty much everyone else has moved to the right-hand side, actually. And actually, Solent were reporting the lowest bed occupancy in the NHS at sub 70% during July 2021. I think there are a couple of points for reflection around the inpatient data, in that if you remember pre-pandemic, that as bed occupancy got more and more difficult, and with that we saw obviously an increase in out-of-area placements and pressure in that area. We might long remember some of those target bed occupancies almost, which were published by Royal College of Psychiatrists and also by NHS Improvement Stroke Monitor, around that 85% sweet spot position in terms of having that headroom to be able to admit patients when they needed to be admitted, and also have good flow within the system. Really interesting to us actually that the Southeast is one of the regions which now seems to be quite close to that sweet spot position, although we are noting that there are still one or two providers that do seem to be experiencing pressure with above average bed occupancy positions, and that would be Sussex, Kent, Berkshire, and perhaps the Isle of Wight and Surrey as well, falling into that category. So this is the region's story of that longitudinal position in terms of monthly bed occupancy. So like the rest of the UK, the region did experience a sort of emptying of beds during first months of the pandemic. But, even with respect, that emptying meant that bed occupancy went down to the low 70%. But it was a better position than the sort of mid-90s that we were used to. And you can see the shape of that recovery there through to the second national lockdown, and then beds again starting to go back to that 80% occupancy, but now recovering again. Now that regional position at 89%, just below the 90%. One of the other dimensions that I know has interested everyone is that use of the Mental Health Act under COVID. And the top chart there shows us the pre-COVID position. Again, quite a range between the region's providers. So before COVID, the national use of the Mental Health Act at point of admission for providers across the UK was 44% of patients were detained. The Southeast actually was higher, it was 45%, but you can see the range there from the Isle of Wight with the lowest use of detention at about 20%, Surrey and Solent also really quite low, through to Oxford Health, who have always been in the top quartile actually in recent years with a high degree of acuity for their patients. And Oxford were in the mid 60% actually. If you look at the bottom chart, that now shows us the July position. And what we can see there is that the story is the story for the UK is that we have seen an increase in detention rates, where half of admissions actually are now under the Mental Health Act across the UK. You can see the regions line up there. I think it's probably fair to say that the region as a whole has experienced more pressure in terms of use of the Mental Health Act. And you can see that in the July data there, where we now have no providers in the region in the lower quartile nationally, with quite a few providers moving to the left-hand side there within that data. Although pleasingly, Oxford have taken some of that head of steam out of the local systems there. This is the story of use of the Mental Health Act across the region over the course of the pandemic, and you can see that pretty much in every month. We just had a couple of months where the region went back to its historic rates, but pretty much across the board, we were above that average position across the region, culminating in that 57% detentions position that we saw in December, now easing slightly to a 52% position in July. So this is the common feature actually across England, across the rest of the UK, that use of the Mental Health Act has increased. So what does this say? Is it an increase in acuity, or is it just about the process of admitting patients now, given there is an enhanced degree of caution about those admissions? So quickly move on to IAPT now. So obviously the IAPT is the largest element of what we might describe as secondary mental health pathways that operate. So we have about 20,000 mental health beds in England. We have about 700,000 people on CMHT caseloads. Pre-pandemic, we had about 1.1 million people who were accessing IAPT. So let's look at what the metrics look like with the latest data. So the top chart here, this is just unbenchmarked data about the demand that's coming through to the region's providers overall during July 2021. And the region is showing very similar demand levels to the rest of the UK, rest of England, clearly, in terms of the data. So it was 1,670 referrals in July to each provider. You can see that the larger providers typically generated more referrals. So you've got Oxford Health, Southern, Sussex and Berkshire very much at the top of the scale there, round about that sort of upper quartile level. We've got some data for you below about non-face-to-face care, because of course the other thing that happened during the pandemic is that we had to drop large elements of face-to-face care and move to non-face-to-face, whether it was telephone or digital. And this happened in really extreme manners to IAPT services. So nationally, across the UK, well, England, during July 2021, we had 95% of all IAPT care being delivered in a non-face-to-face manner. So only 5% of IAPT care was being delivered face-to-face in July. The South East was broadly similar, 97%. Including a number of providers where it was 100% non-face-to-face, so Berkshire, also Oxford and Solent, pretty much 100% there. The one provider really that booked the trend actually was the Isle of Wight, where we had about 85% of IAPT care being delivered non-face-to-face. So credit to the Isle of Wight, about 15% of IAPT contacts were delivered face-to-face during July. And of course, the anecdote is that most of that care perhaps became digital. So what we've done is we've looked at the digital data, and there has been some really incredible progress around digital across England, and the South East providers are no different really on that one. So what we saw is that across England, 26% of all care was delivered digitally in July. Remember that 5% of care was face-to-face. So what does that mean? Well, it means that 69% of care was still delivered via the phone in IAPT services in July. So that's a metric we really want to keep monitoring and ensure telephone-based contacts for common mental health problems is probably, one of the clinical specialties where we'd feel more comfortable with that approach. But we'll be really keen to keep an eye on digital contacts and also face-to-face contacts as the year progresses. You see that the South East did better than the England average, though, in terms of its digital position, with 34% care being delivered digitally. And third best nationally was Solent, close to 50%, and Southern actually were about 46% as well. So some huge digital delivery down in that patch. Also Berkshire, Sussex, well over 30% there, and Oxford and Surrey also above the national average. So if you add that face-to-face care for the region, which remember was 3%, to the 34% being delivered by digital means, it's just 63% of care now being delivered via the phone in terms of IOP. And this is the story really of that increase of digital care month by month back for the South East providers over the course of the pandemic. I think what interests us here is that we haven't seen that ongoing climb, with the peak really occurring in April. And as we've got more used to face-to-face care coming back as that third national lockdown eased, it's interesting that things seem to have plateaued. So digital has not carried on accelerating. We've seen a marginal increase in face-to-face care. So there's really an open question from us to everyone about whether we're now in an equilibrium position where telephone-based care has become really a sort of de facto default offer almost for the system, especially around IAP care. I hope that was useful. So we've covered inpatient beds, we've covered IAP. We're now just going to have a quick look at CYP MH services. So there has been a lot more volatility around CYP, and a lot of this is tied up, of course, with the with schools being closed and what that does to referral pathways for CYP MH services. One of the things we wanted to emphasise, though, is that remember when I showed you that UK map of adult acute beds at the start of the presentation, which has the region very much at the low end with 30% fewer beds. So that sort of light blue or mid blue colour. It's interesting when you look at CAM's caseloads across the UK, you don't see the region occupying that same colour scheme. And that's really because the sort of morbidity around CYPMH is very different from that traditional patterns of demand that we've seen with acute mental illness for adults. And you can see this on the national map here, where a lot of the region's geography is occupied by areas of incredibly high demand for CYPMH. And that's sort of articulated in terms of very high caseloads. So you'll see from the map there that the Thames Valley area in particular has some of the highest caseloads anywhere in the NHS. Surrey also has really high demand, and also the sort of Hampshire, Isle of Wight, Sussex zone, also really high demand levels as well. The one area that's not reporting above average demand at the moment is Kent and Medway, although some of that is really because of the NELFT provider position for that patch and being able to confidently separate that data at the moment, which is very much a work in progress issue. So part of the story around CYPMH is really about different patterns of demand, and actually the southeast is one of the hotspot zones for high levels of demand, high levels of referrals, high caseloads. So we'll start to look at the referral story now for CYPMH. I think most of you have seen these charts, seen this chart before, but it's one of the most powerful charts that we use actually in the whole of our work program. So it's this notion that CYPMH is the fastest growing major specialty in healthcare of any major specialties actually. And really that story emerges if you look at the blue area of the chart. So our historic data goes back about 8 years in the pre-COVID position. And the first blue bar there shows that in 2012-13, the number of referrals for young people to mental health services was 1,857 for 100,000 young people in the 0 to 18 age groups. But look how that started accelerating. This is all pre-COVID, but where did we end up? The final blue bar was 3,872 referrals per 100,000 kids in the pre-COVID years. So basically referrals to CYP MH services doubled in the 8 years prior to the pandemic. So CYPMH is a major specialty. We spend about £1.1 billion a year. That's about 1.1% of the NHS budget goes on CYPMH services. And we saw a doubling of referrals in the 8 years prior to COVID. The red bars on the chart though, this really shows on a monthly basis what happened under COVID. So the first bar, April 2020, the first red bar, 1,821 referrals per 100,000 population. That basically shows us that referrals fell by more than a half. So we had a 53% drop in referrals in April 2020. So there was almost this quarterization CYPMH referral pathway that we saw as schools closed and as primary care got difficult to access. We had really quite a rapid recovery though through the summer. so that by July referrals we're getting on to sort of levels that we were quite familiar with. Bit of a drop through that late summer period, but by September referrals have breached the pre-COVID levels. Some of that pent-up demand came back, and then we were really into this sort of domain of referral levels in terms of articulated demand being much higher than anything we were ever used to before. A bit of a drop during that next national lockdown, but when that was released in March, you can see that the pent-up demand really started to come through in an accelerated manner. So those 4 months from March through June 2021, we were seeing referral rates generally in that 30% higher than anything we'd seen prior to the pandemic. The good news in July is that we're starting to see a little bit of a levelling off now. And referrals now are about 9% in July, higher than they were in that pre-pandemic position. But it's been an incredibly volatile ride for everyone in CYPMH services. So it really does raise significant questions for all of us on that modelling front about where next for CYPMH services. What can we draw from the data? What can we draw from the referral from the research papers in terms of where we might go next? So that's really why the modelling tools come into their own. So this is the position for the region, actually, the latest data for July. So the national data is 355 referrals in month per 100,000 population. Remember, that's now 9% higher than annual rates. The region's position is very close to that now. So we would argue that's a good news story for the region that, okay, we've got high demand levels than we used to, but we've got that almost levelling off position starting to emerge for the region, just as it has for the rest of the UK, hopefully. But look at the range within the region. So Oxford Health, very, very high referral levels there, 5th highest in the UK. Surrey, well above average, and also Berkshire. So we still got that hot spot of the Thames Valley, and Surrey, very evident within the data. Isle of Wight, close to average. We've got the 2 parts of the Sussex delivery. Remember, that also covers Hampshire as well, and also Solent, interestingly being in the bottom quartile at the moment in terms of the latest referral data. That's the cycle of the demand profile for the region's providers over the course of the pandemic. It's quite consistent with that national story you saw earlier of demand drops, recovery, next lockdown, demand drops, and accelerated referral rates coming through. But I think there's a strong story for the region here, where for the last 3 months, the region's referrals have settled almost into a pattern which is quite familiar with what we were seeing in the pre-COVID age. So big question to everyone there, are we seeing almost an equilibrium position emerge across the region now with 3 months worth of steady data there? The caseload data, though, this is the most recent data in terms of the patients that are being looked after by individual services, both within across the UK and then within the region as well. You'll notice that the hotspot bit of the story is very evident within the caseload data here. So UK average data is 2,060 young people per 100,000 on caseloads in July, and that's 28% higher than where we were pre-COVID. So, that whole volatile ride that we saw has left us in a position of 28% higher caseloads in CYPMH. But look at the region's position there. So we've got a position across the region now at 2,642. That's now 30% higher than where we were pre-pandemic. So those real peaks of referrals have left us with bigger caseloads across the region. And if you look at the provider-specific story there, we've got Berkshire, 2nd highest nationally, Solent, 3rd highest. The Sussex partnership patch into Hampshire, also in the top quartile. Surrey, round about average now, but remember that's an average which has risen 28%. We just got 1 or 2 data quality issues around the Oxford caseload data, which we're looking at the moment. And then Isle of Wight are also, Isle of Wight are in the bottom quartile at the moment. But remember that this is a plane which has shifted up by 28% for all providers across the COVID period. That's the region's story in terms of caseload. I mean, credit to all providers here as well, in that although we saw those huge sort of oscillating peaks and volatility in the referral volumes, what we saw for the region actually was that people were not discharged from caseloads and that care was kept open during the pandemic. So for the region as a whole, really, we've seen higher caseloads from the start of the pandemic, which has been maintained over that 16-month period. And you can see now that 30% above steady state positions being reported across all providers in the region there. So CYP-MH demand has been uplifted, but we're now seeing a position for the region with 30% higher than where we were pre-pandemic in terms of caseloads, but the referral rates seem to have steadied off now with 3 months of consistent data coming through. In terms of contact rates, again, there are always DQ issues about the contact rates. And of course, we're counting telephone, video, and also face-to-face contacts here. The region's maybe about 5 or 10% below the national average in terms of the July data, but remember that the caseloads are 30% higher across the region at the moment. So there is a bit of a data quality question we've got here with this month's data, which we carrying on working with providers on at the moment. And in terms of that contact story and the recovery story, you can see that the region is getting back very close to where it was in the pre-COVID story there. But you can see the story of volatility within the region's data there. And July, actually, the contact rates were 9% below what was being reported in the pre-pandemic position. Digital, like IAPS, CAMS has done incredibly well, actually. Really led the way, and the top chart there is a UK-wide story where CYP-MH in the first month of the pandemic managed to switch to 11% of all contacts on a digital platform. Really rapid acceleration though in these subsequent months through the summer. Reached its peak actually during February at 27%, now stepped back marginally to 19%. So we've been fascinated actually looking at this data that as face-to-face care has come back, what we've seen actually is a slight lessening of the digital offer rather than a slight lessening of the telephone offer. So again, it raises that discussion point about whether the telephone offer has become almost a de facto first entry point for some services. So again, that's an issue we'd like to see, maybe some observations from providers about what's being delivered on that telephone first care offer, with some of the digital offers starting to peg back slightly now in recent months. However, we must remember that the South East is probably the best performing region of all, actually, in terms of the digital CYP offer. And if you look at the data below, so remember, nationally it's 19% of all care is offered digitally in July 2021 across the UK. The South East, though, are doing about a third better than that, with 24% of all CYP care being offered digitally in July. And you can see that we've got Oxford, we've got Sussex partnership in both Sussex and in Hampshire in the top quartile, as are Berkshire and Surrey also well above average. We just got Solent actually in Isle of Wight that are currently below that national average position. There's the cycle of that regional delivery, and you can see that we've got a slight tailing off now as face-to-face care starts to recover across the region. I hope that was okay in terms of the data. Maybe, Katrina, I might just pause there for a quick drink of water if anyone has any questions.
Thank you, Steve. Yes, we have question from Helen. Hi there, Helen.
Hi, Katrina. Hi. It's probably more of an observation. So I've just been checking out behind the scenes whether the SIPS data for caseload includes the whole range of partners. So in Surrey, we have an alliance model, which is a formal alliance with the third sector, and so it's sort of joint delivery. And I'm not sure that, I don't know if that data is collected. I don't think it is. I think this is just SABP data, so it sort of doesn't reflect the whole of the caseload or the demand data, really.
It's very much for HSDS positions as a corporate entity. So what I don't know within that is whether you're owning any of that data that's being delivered in partnership with the VO providers. If it's not and they're submitting their data to NHS Digital centrally, then yeah, we're just talking about perhaps just talking about the statutory providers. But you're right, we live in an increasingly diverse world, don't we, where the VOs are a part of this story, which we shouldn't forget, really.
Yeah, absolutely.
And just to pick up, Helen, your point, it's also been raised, Poppy, I know you've raised that in the chat in relation to whether IAPT, non-NHS IAPT providers could be included, their data. And this is something, Steve and colleagues, that we looked at previously, wasn't it? And I think where we ended up was that wouldn't be possible, unfortunately, given the way that the data is collected through NHS providers.
Yeah, unfortunately, we're not cited. I mean, there are about 150 IAPT providers in England, and obviously there's only about 54 statutory mental health trusts. So there's a whole amount of diversity happening out there in terms of the provider landscape. I mean, statutory providers are still delivering at least 2/3 of the national IAPT contacts. So I think the statutory providers are really the kernel of that story. I think what we can offer, Katrina, is that in the latest version of the modelling tool, we've now included an IAPT zone where people can explore the data. But you're absolutely right. We should not forget the other providers. NHS Digital are making some of that stuff available now, but there's just really quite a long time lag on some of their data. I think they're at Q1 at the moment in terms of the national data, but it is worth keeping an eye on, and we'll do our best to include that as far as we can. Okay.
Thank you, Steve. And actually, Poppy, your hand's up.
Yeah, no, it's just to say, I agree with the time lag situation. I'm sorry, I'm Poppy. I'm the data analyst for the Kent and Medway Mental Health. So IAPT is my baby, it's my thing. So yeah, I do understand that the time lag is frustrating, but surely could the SDCS submissions not be a source, because all IAPT providers should be, like other providers submit to the MHSDS, all IAPT providers should and do, as far as I know, submit the data to the SDCS. Could that not be used as a source to look at, or is that too fiddly, or?
I think it's a possibility, Poppy, and if it's important, then we should look into it. We don't have access to that, I think, is the only problem, and we probably need...
anyone can download it on the NHSD website. Anyone can have access to it. You can, member public can download it if they want it.
Sure. Okay. Well, I tell you what, we'll do our best to supplement that for the next version of the modelling tool, right?
Okay.
We've got the statutory providers, which you'll see in a moment, included now. But you're right. Let's see if we can get the rest of the market included as well. Yeah.
Okay. Thank you.
I mean, it's a really important point, this, because of course IAPT was about 30% down in terms of referrals and contact rates for most of last year. So knowing where we are with IAPT recoveries is a really important part of the story. And anecdotally, people are starting to report really long waiting times at the moment for IAPTs, which is not what we used to, because it was the most rapid access part of mental health services historically.
Yeah. No, that would be incredibly helpful, Steve. And obviously, some of the data you collect is different. So, for example, the digital, the method of delivery, that kind of thing. But still be really useful, given that two out of our 6 systems, and actually other systems also have non-statutory providers as well. So that would be brilliant. But just wanted to raise something in relation to IAPT and telephone interventions. Just given the data that's coming through that you were reporting, which is some very recent national guidance that step 3 interventions cannot, moving forward, or the national guidances should not be delivered by telephone. They should be delivered either face-to-face or remote video platforms. So it would be interesting to see that guidance has gone out to IAPT providers and systems across the southeast. But it'd be interesting to see as that data kind of develops in the context of that guidance.
I'm really pleased by that, Katrina. I wasn't aware of that actually, and we've been watching that IAPT face-to-face care thing be very static actually, at between 1%, 3% and 4% for 16 months, and we've been waiting for the dial to shift. So maybe that's the catalyst to help it.
Yeah, brilliant. So, Steve, I think, are you going to talk about the modelling, and then we're going to have a break?
If I very briefly just let everyone know where we are on this one, I think that's probably the best thing we can do. And then we'll take that 10-minute break. So first up was the literature review, and this is, of course, embedded within the modelling tool. And We just brought 4 reference points for today. Remember, we've got about 23 different academic and peer-reviewed papers reviewed in the modelling tool. So it's a great go-to place, and we are keeping it up to date. But obviously, we're in this strange position now where we're sort of post-vaccine and people starting to interact face-to-face. It's going to be fascinating to see what that pent-up latent demand looks like that services may need to respond to. And we're seeing CYP demand come back, well, actually accelerated demand, but one of the big stories we'll look at after the break actually is that CMHT referrals have come back to pre-pandemic levels as well. So what next? And we are looking at a number of updated research papers. So the Centre for Mental Health work, which I know Katrina and team are very involved in actually with, making some really quite significant macro projections about what the long-term impacts of the pandemic might be over a 3 to 5 year planning horizon. Some of that is going to appear in the next version of the LIT review. We've got the impact of NHS staff actually in terms of, almost a microcosm of what's happening within the wider populations. This is not staff absence because of COVID, but it's about the mental health impact of COVID on NHS staff, where we're starting to now see increases reported. So there's a very recent HSJ piece there. We've got HEE's enhanced investment in IAPTs with a recognition of anticipated demand increases there. I think in many ways the most interesting area of the new research around COVID demand is on the CYP front though. And obviously the NHS Confed Mental Health Network issued really quite a striking paper last month with an anticipation of an additional 1.5 million children that may need some access to mental health services due to the pandemic. And they're particularly tracking the demand in the urgent care pathway, as well as other aspects of the system, such as eating disorders. So we'll be keeping an eye on that as a group, and you'll get access to a synopsis of that paper in the next version of the modelling tool, where we're going to embed that literature review. Just a reminder then on the modelling tool. So I'm probably going to do this initially just as a hard slide based rather than jumping to the modelling tool, so that we're not late going to the break, but we might come back to that modelling tool later in terms of maybe some interactive questions that people might have. So remember, it's an Excel based platform which you can download onto your desktop. Michelle did actually make the most recent edition of the tool available a few weeks ago. That was the edition that was updated to March 21 data. We're going to make another version of this available to you with that July data, probably in about the next 10 days or so, with everyone's, remember it's UK-wide data as well as the regions data and that LIT review included within it. So you can look at any of the metrics that we've talked about today, and you can also play around in terms of surge management trajectories within the tool. So we look at adults, CYP, learning disabilities, and also the IAP sectors there. You've got the LIT review you can access. You've got a comprehensive user guide you can look at, and just an illustration there of that user guide telling you how to operate and drive the tool really with those regional maps which are embedded within that. You can look at a whole range of analysis. So in the inpatient domain, for example, you can look at bed occupancy. There's a very long menu list. You can, not just the adult acute beds, but you can look at old age, you can look at PQ, you can CYP, you can look at secure beds, rehab beds, etc. You can take a UK-wide view of data by any month at any point during the pandemic, and then you can switch that view to look at the regional configuration as well. And when you get to that regional data, it's not anonymized like the national data. You can look at provider-specific returns for any month and any menu option as well. So there's some really rich data now, which is building up, and obviously you've got all that longitudinal data as well. In terms of the modelling zone, you can look at inpatient and community trajectories. We'll talk about community later, and then you can play around in terms of your local surge capacity planning work. So we'll just start by looking at very quickly at the acute inpatient trajectories. So you can look at individual providers. This is Berkshire's data. So we're tracking Berkshire's position in terms of their actual volumes, and you can see the the longitudinal chart there showing the peaks and troughs of those acute admissions. So that initial drop followed by recovery, and also the position about the demand that was missed and what we might do with that in future in terms of modelling. So you've got that area within the modelling tools there where you can anticipate maybe going back to some of these services that couldn't be provided over the course of the pandemic and what the recovery might be, maybe now more relevant in community-based care than inpatient care. So that's that recovery in inpatient services. You can also look at specific scenarios within that. So for example, if you are anticipating additional admissions, you can look at that by provider, and that will tell you the impact in terms of bed occupancy and also maybe additional beds that you might need both within the NHS and then maybe any overflow beds into the independent sector there, and where you might be in terms of your thresholds on bed occupancy. And you can do that on community services as well. And indeed, it was probably community services where there is actually most potential for that recovery story to play out in terms of care which we couldn't deliver during the pandemic, and what that trajectory of recovery might look like in terms of additional services, which you can see on that bottom chart there, with those additional community-based interventions being delivered on that bottom chart there. So I hope that was helpful, Katrina. I think we're just on time now at 3, if that's appropriate, to maybe take that break, and then we'll come back to talk about some of that community data and open up for a wider discussion.
Absolutely. No, thank you very much, Steve, and colleagues. As always, it's incredibly helpful to have such a rich narrative in relation to the data. I mean, whenever I hear the updated presentation, there's always so much to learn. So huge thank you for that. Just before we move on to the break and the community section of the agenda, it would be good just to respond to Helen, your point about where the data gets stored. And Michelle, you did respond to that. That is something that we're looking at the moment. I don't know, Michelle, whether you want to provide an update.
Yeah, so essentially I was having this conversation with Steve and the team about where we could store the modelling tool. One of the suggestions that we had was we do have a clinical network website, and that we could potentially put a hidden page within that website so that you'd be able to access the tool there. And also perhaps we could record NHS benchmarking, giving a kind of a tutorial on how to use the tool so that everything is in the same place. But if it would be easier for it to be stored on a features platform, we could do that as well. So you've reminded me to ask the question. So you may not want to answer that now, you might want to have a think and get back to me. But it's definitely something that we wanted to explore with you.
Brilliant. Thank you, Michelle. And I just wanted to mention that there was a message on chat, I think, Bikram, you raised about some of the data that hasn't been included, Steve, in your presentation. Obviously, really helpful, but that is just a snapshot. There's a lot more.
It is. We've got many thousands of lines of data actually now in the tool. 16 months of each of the metrics. So we'd really encourage people to have a play around with it, and it's an open invitation, really. As Michelle said, we do hope to record a tutorial webinar. If anyone would benefit from a local webinar for their system, just let us know, and the team can get in touch and organise something for you.
Brilliant. That's really helpful. Thank you very much, Steve. So I think we're going to just before we move on and take the break, just for those of you that aren't going to be staying for the community section, there's a couple of dates. We've got Tuesday the 7th of December and the 8th of March. So as for those of you that have joined these sessions previously, it's kind of an update as to where we are now. And that's the next date that we've got. I mean, Michelle, have those invitations gone out yet, or they will be going out shortly?
They haven't gone out. They're just in the internal comms. But what I'll make sure is that we put a save the date invite to everyone. And perhaps what we may need to do is kind of, again, split it into 2 parts. So you may find that you want to come to part 1 to kind of get the overview, and then part 2 will try and focus in on a specific area. So you may find that the second part it is not of interest to you next time.
Brilliant. No, that's great. Thank you, Michelle. So again, any suggestions for the next 2 sessions for what you would like that kind of part 2 to focus on, that more in-depth kind of discussion, but also looking at the data? That would be really helpful to support our planning moving forward. So either put that in chat or contact us as a team and let us know if there's any particular interest around those sessions. Brilliant. So huge thank you, Steve, and to the team. As always, absolutely brilliant work. We are going to be coming back. So if we come back at 3:10, have a quick comfort break, and then we'll be coming back and hearing about the community story for the South East, and then having some discussion as well. So thank you very much, everyone.